Hey,
There we
Oh,
go.
thank you. I will let Lori know. Thank you so much.
I didn't know we were the host. That's fun.
Look at you guys, you're the host.
First time.
And do you know how to save it?
I believe so.
Okay.
It'll pop up on the account. So it'll go back to the account. It should be
Great.
fine. So
Okay.
And that before we log off, before we end the meeting. Yeah. Okay.
Yeah, so thank you guys for your time. Feel free to reach out to me at any time if you have any questions, ideas, thoughts. We're definitely open to it, as this is a new kind of process, and it's in that development stage, and so we appreciate any support.
great. All right. Thanks so much, Kelly.
Yeah, thank you
Appreciate
guys.
it.
Yeah.
All right. It looks like the next item was introducing the R.E.A.L program, and it lists Jim Novelli, but I don't see Jim here. Was somebody else going to do that presentation?
I think Lori was saying early on that someone else was in short notice not able to make it. So I'm guessing if no one's jumping out, that might be the person that had to step out at the last second.
Okay. Okay. Well, then we can move on to Amy and Debra with
Sure,
OCH.
this is Jolene. I can kind of talk about it from the regional perspective.
Sure. Okay.
That would be helpful.
Yeah.
Trying to get my phone to work. Hold on.
Because there were some, yeah, so after there are some slides available. I don't know that I can, let me see if I can share screen. Yeah.
Well, I have not seen them. So
Okay. Well, here you go.
oh. Oh, they just took our materials, it looked like, so that's easy enough. So I'm not going to follow the slides because I can't quite see them. I am on my phone today. So just wanted to give a brief update since it's on the agenda. So we have been talking for a good period of time that we anticipated the Recovery Navigator program coming secondary to the Blake decision. We have coined the name the R.E.A.L program, Recovery, Empowerment, Advocacy, and Linkage. That is how you will hear this program referred to across all three of our counties, Kitsap, Jefferson, and Clallam. We have 5 teams across the 3 counties, 1 team in Jefferson. That team is housed with Discovery Behavioral Health. The teams will include a project manager, a care manager, and 2 recovery coaches. The project is very much engaged with lead core principles, harm reduction, trauma-informed care. The focus is individuals who have substance use or co-occurring disorders, who have had frequent legal involvement, law enforcement referral, but we also is the priority, but community referrals are allowed. We are working, I'm seeing the slide. We are working on the development of the policy development work group, as well as an operations work group that would include other navigator programs, law enforcement partners, court partners, community service partners across the board. And that work will be done primarily in partnership, primarily by DBH in partnership with the Salish BHASO. Yeah, so sorry, it's kind of hard on the fly. I've been kind of living and breathing this program.
I think that's good. I think that, everyone received the slides, certainly going through those, a lot of good information there. Yeah, it says that you guys are working on the formation of the policy work group and the operational work group. Is that correct?
Absolutely. So there should have been emails that went out yesterday from Marianne Lewis. She is our she is the R.E.A.L program administrator with the ASO, so overseeing all 5 programs. And she is reaching out initially to law enforcement and navigator programs, as that is our first line of engagement.
Okay, and Kelly wanted to know if the R.E.A.L program supports adults and youth in the justice system.
So the R.E.A.L program is a community-based program. So it is expected to be community-based outreach for folks with involvement. And yes, it does serve adults and youth. There are no limitations on who can be served by this program, with priorities around individuals with substance use disorder and co-occurring needs.
Okay, any other questions that Jolene may or may not be able to handle?
I have a. Go ahead, Greg.
I think Commissioner Brotherton's just not muted. He's fine. Go
Oh.
ahead, Nat.
Well, Jolene, I appreciate the on the fly presentation. I'm not going to grill you with questions. I read through the materials, and I think this is a really positive development for our state and our community, and definitely comes on the heels of a real creation of a vacuum. I think we can all agree that Blake was not something that a lot of people expected, and it created a real vacuum, particularly for small counties to have programs that are alternatives to the criminal legal system. And we welcome these alternatives. I think that the R.E.A.L program looks really, really great. How do we get in on this? We want to be partners. So, and I think we would be valuable partners for both work groups.
I agree, and you actually are on the list.
Yeah, I see that, but I just don't know, I haven't received the email, so.
Yeah, like I said, we are just in the development phases with these work groups. So I anticipate sharing information with this whole group. So you could reach out to me directly, or Marty Ann Lewis with the ASO, or Jim or Leanne over at DBH. But I will make sure that you.
I'm going to send you a chat right now.
Thanks,
Jolene.
You bet.
And David, you had a question?
Yeah, Jolene, this is great, and I think a really positive program, and just adds to the, sort of another brick in the foundation of caring for patients. As someone who represents mostly end users, so as the medical director for EMS, is there an org chart of where all the programs fit and who does what and who interacts and where the entry point is, so that a nice EMT who maybe the navigator's not on duty at the time can help someone navigate that? I know there's a resource card, the yellow card, that has lots of different resources listed, but I wonder if for the person on the street, I think it would be helpful, and maybe I'll turn to someone who's closer to me, to the street, Chief McKern, but I think it would be helpful to have sort of a org chart of if I'm seeing a youth or an adult, and if they have substance or no substance, and like where do I go and how do I access that?
So we actually are working with the printer this week to have some quick pocket cards available with the contact phone number for the team. So we are in process of printing those. We hope to have those in the next couple of weeks. There is not a flow chart because this program doesn't follow enough of a flow. It is very much client driven. But fire EMS are on the same level as law enforcement in the reach out for development of these groups. So we should be in touch with your folks fairly soon as well. We literally, first emails were sent out yesterday.
Okay, work in progress.
Yes, we're very
It's too
excited.
bad that the sheriff's not here. I know that there's connectivity issues with the county, but Jolene, do you know, has there been any report of law enforcement kind of putting the brakes on any sort of getting to that third stage of the, how there's the 2 referrals and then law enforcement can actually charge people under the new statute? Do you know if there's been any efforts to go that direction, or are they waiting until something tangible like R.E.A.L is set up so that they can do referrals? Do you know?
That would be a better question. I know that across the state, that has been a challenge for jurisdictions on how to track those 2 contacts prior. I have not heard anything specific related to Jefferson County, other than some conversations with Sheriff Nolan trying to figure that out. I think this program, upon full rollout, will definitely help with that.
Great.
I
Thank
do,
you.
real quick, I do know that referrals
or at least the forms are being given to individuals. It becomes then up to the individual to contact either my agency or Safe Harbor. But I have seen some of those referral forms, but I don't know like where that ends. I know that our law enforcement is actually very good about trying to work with people and get them services rather than just putting them in jail.
Hi, this is Lori. I have managed to get on. I had to drive home. Apparently all of the county is out, and I want to thank everybody for just going forward. I know Jim Novelli let me know last minute that he wasn't able to make the presentation. Jolene, I appreciate you stepping in. And I don't want to interrupt anything. I just want to make sure we have a solid block of time that we can go through the stigma presentation that OCH has so graciously brought to us today. So tell me where you're at in the R.E.A.L discussion.
We're just finishing up. Jolene was just trying to answer a couple questions that folks had.
Great.
Yeah. That's it. Did anyone else have any other follow-up? Okay. And
Okay.
I'll stop share because I think Amy and Debra can control their own slides. So.
Great.
Thanks, you guys.
Yeah.
Okay.
And I'll let you take over, Lori. They
Thank you,
put me
Chair.
in charge. Always dangerous.
See, who needs a leader when you got Cherish? So you folks may remember that we had OCH come, I think it was back in August, and they did a focus group with us. And they are back now to sort of give us some of the results and to think about next steps. So I'm going to hand it over to Amy Brandt and Debra Swanson. Thank you for being here.
Thank you, Lori. Are you seeing our full slide without? Yeah, okay.
Yeah, looks good.
Hi, everyone. My name is Debra Swanson. I'm here with Amy Brandt from Olympic Community of Health. We are thrilled to be here today to share with you this presentation focused on addressing stigma of substance addiction, ultimately to become a recovery-friendly region. There will be opportunities for discussion woven into this time together, and there will be time for questions at the end.
There we go.
Okay, sorry, thank you.
I can do that.
Okay. Olympic Community of Health is a nonprofit with the purpose of tackling health issues that no single sector or tribe can tackle alone. This core theme of collaboration inspires the projects, partnerships, and goals of OCH. By bringing together clinical partners, community-based organizations, tribes, hospitals, elected officials, and others on local health issues, like stigma of substance addiction, we ultimately work to foster a region of healthy people and thriving communities. First, I'd like to acknowledge Cambia Health Solutions. They provided OCH with funding to explore and take action on this topic. I'd also like to thank the team at Collaborative Consulting who helped us compile a lot of the data you'll see today. Finally, a very special thank you to all of the regional partners who took part in the surveys, focus groups, and key informant interviews. Your voices are incredibly important to this work and to the next steps. Earlier in 2021, we engaged a small consulting firm, Collaborative Consulting, to complete a literature review and an analysis of available data. On the qualitative side, we conducted a region-wide survey and spoke with community members through focus groups and interviews. We compiled a summary of what we learned in the next several slides. In one of our closing slides, we'll share links where you can access the full reports if you'd like to dig a little deeper on this topic. We'll only scratch the surface today.
Thanks, Debra. Like Debra mentioned, we're just scratching the surface. This is about a 60-minute presentation boiled down to 25, and we're going to speed through it in 18. So I'm just going to touch the surface about what stigma is, and then we'll dive right into some of the outcomes of these research activities that you were involved in. So stigma is basically the social practicing of labeling, stereotypes, separating us versus them, status loss, discrimination, and the practice of power. And this is often driven by a lack of knowledge, a lack of experience with people of a specific group. So there could be a stigma of mental health, stigma of substance use disorder, stigma of race. There's all kinds of different stigma. So today we're diving into stigma of substance use disorder, and stigma manifests in multiple dimensions. So there's self-stigma, interpersonal stigma, community stigma, and structural stigma. And there's a lot more information about this that we'll share how to learn more at the end. We're going to dive more into the impacts, which on the next slide. Perfect. So this slide here kind of boils down the key themes that we heard from our focus groups and the participants in our survey of how stigma impacts communities. So stigma is often seen as a choice. Individuals with addiction are seen as weak, making poor life choices, lacking in willpower, and are to blame for their addiction. They're also assumed character flaws. People are labeling, they're stereotyping. Then there's social rejection, and ultimately this feeling of lost humanity. And the further impacts down the road is a resistance to treatment services, and then an internalization of the stigma on that self level. In the next slide. This is where I added some fun animations. So diving into the data points of this information, we've got the Olympic region, the percent of population with identified substance use disorder in the past year in the Olympic region is slightly above the Washington state average and also above the US average as well. And then if we take a look at youth, we've got about 1 in 5 10th graders in the last 30 days. This is back in the last Healthy Youth survey that went out, reported drinking alcohol, and about 1 in 4 reported smoking e-cigarettes. And then if we look a little bit at the treatment numbers, we've got, so out of the Medicaid beneficiaries in the Olympic region with an identified substance use disorder, about 1 in 2 adults have received treatment and about 2 in 5 youth have received treatment. So these numbers just help us get an idea of what the current prevalence of substance use disorder is in our region and where there are some current gaps in treatment and how we compare to the state. And I'll pass it back to Debra. Yep.
The next set of slides looks at what we learned from the qualitative research we conducted. We heard from over 200 people via our online survey. We conducted 10 focus groups, 3 of those in recovery for SUD, and 2 key informant interviews. Of those who participated, the majority believe that stigma is a problem in the Olympic region, and most of those believe we should be addressing it. Among those who do not think stigma is a problem, shared that focusing on stigma enables individuals with substance addiction perpetuating addiction. If stigma were to be addressed, this group believes it will lead to acceptance of addiction. On one component of the survey we conducted is a validated perceived stigma scale. This is an 8-question scale that measures self-report of perceived stigma towards substance users. It assesses beliefs held about the prevalence of stigmatizing attitudes and actions in society. We learned that there is greater perceived stigma in the Olympic region compared to other communities. Based on survey responses, most respondents believed that people in the community perceive individuals who have been treated for substance use as less trustworthy. They believe that most employers would pass over someone in treatment in favor of another applicant. They believed that most community members think less of individuals who are in treatment for SUD, and they don't think the community would accept or hire them as a school teacher or a caregiver for their own children. Although participants described how many people working in the substance use disorder field are compassionate towards those with addiction, they also expressed ways that provider addiction stigma manifests in the health and social care delivery fields. Individuals with an addiction feel they are treated differently than others. They feel unheard and that their health issues are dismissed or ignored. They feel judged and treated with suspicion and assumed to be drug seeking. Some providers are reluctant or lack training or comfort in managing addiction as a disease. In some cases, we heard about individuals being screened out of services or denied care due to their addiction. Another element to consider are the environments and spaces where people go for SUD treatment. They often are treated in second-rate or dilapidated buildings, which gives them the impression they have a second-class illness. Not only do they worry they will get poor quality care because of the stigma of their disease, they also get the message that they are not worthy of high quality care and environments where people with real diseases are treated. My mouse is being tricky. All right. So here are some quotes that we heard in the focus groups. Rejection. Patients come in with a lot of guilt, a lot of remorse, and often what you'll hear is they've been rejected so often by the healthcare system, by other providers, by their family, by their friends, by their employers, that just to come through the door and ask for help is huge. Dehumanized. Their value as human beings are diminished, and their talents and role in the community is often overlooked because their substance abuse issues are in the forefront. Judgment. A client shared with me that a provider told them, yes, I could do this surgery for you, but then you would just keep using. So what would be the point?
Thanks, Deborah. We're going to skip this discussion and then do discussion at the end just for the sake of time. So what we just heard were the key findings and themes that came from the focus groups, the survey, the key informant interviews, and the background research that we did. So we've just heard a lot of information, and from the OCH perspective, stigma of substance use disorder is something to really take seriously, and we want to address collaboratively. So this next set of slides summarizes how OCH will be responding and how you can join us in taking action. Our overarching goal is for the Olympic region to become a recovery-friendly region, a region that supports prevention of substance use disorder before it starts, that provides adequate access across the region for evidence-based treatment, one that supports those who are in recovery, and that is there for our fellow community members if they relapse. So a place to start is by addressing determinants of health, and this has been a focus of OCHs over the past few years. So determinants of health are the conditions in which we live, learn, work, and play. So factors like long-term quality, affordable housing, safe neighborhoods, good food, quality transportation, reliable transportation. So we have a lot of amazing partners who are here in this room today that are creatively addressing and tackling these determinants of health across the Olympic region. In the beginning of 2021, we released a behavioral health report that really highlights the need for withdrawal management resources in order to provide additional beds and really fill those gaps in the region. So this is another area of need that we have lots of resources to provide more information about this as well. Additionally, we want to support policies, as policies can both positively and negatively impact stigma. OCH will be reviewing policy proposals through this lens and through all the information that our communities have shared with us about the way they experience stigma in the Olympic region. And we really encourage others to do the same and advocate for decision makers as appropriate. We also see a lot of potential with trainings and learning opportunities across the region. Through the focus groups, we heard a lot about the continued need for professional development, learning, and training to reduce stigma. OCH will continue to support and encourage participation in trauma-informed care, harm reduction, reducing bias, and more. We're also really pleased and excited to share local trainings that our partners are putting on as well. So feel free to connect with us if you have local trainings that you want us to help promote. We also see a need for focusing on positive youth development. So part of preventing substance use before it starts is through positive youth development. The philosophy that young people are assets to be cultivated, not problems to be fixed. So through youth engagement and partnership, we can work alongside young people in the region to address and reduce stigma. Finally, we know that many of you support and advocate for peer services and supports. OCH would like to continue to foster this movement and to support these positive impacts that peers have on those in treatment and recovery. So this next slide has some quick little ways that you could tangibly make change in the near future and long future. We've got some ideas about really pursuing to learn more about person first language, diving into your own personal bias, maybe taking a quiz online about bias, or having a workshop in your organization or tribe. Also taking steps to learn more about current addiction science and brain science that keeps evolving, and encouraging the people in your scope of work to be open to these new trainings, these new approaches and solutions. And then, so through youth engagement and positive youth development approaches, so sharing those success stories and really seeing youth as a partner. And more tangibly, Olympic Community of Health will be hosting several action collaboratives in 2022. One of those, for example, will be focused on substance use disorder, and another will be on housing. So there's a lot of opportunity, a lot of overlap with stigma in these focus areas that OCH will be conducting these groups on. So we really invite people to bring their expertise and their perspectives to those groups. So that was a lot of information. Now I want to turn it back to you all. We have a couple questions. I also want to open it up just for any comments or what surprised you from what you heard, what challenged you, what really resonates. And ultimately, this is a space for you to collaborate with your group, with your peers and colleagues across the county of how you want to address stigma of substance use disorder in your community. So I'll turn it over to you guys right now. Did anything particularly resonate with what you've seen, or a specific opportunity that you think would be great to pursue?
Oh, hi, Patrick Johnson here. I'm sorry, I'm on the beach, but I want to ask a quick question. Can your focus groups be replicated with mental illness?
So there's, we decided on these focus areas by doing a lot of conversation with our partners, and they narrowed it from a list of about 100 topics down to these 4. And I think mental health, behavioral health applies to all of the focus areas. And I think we just wanted to integrate that into the conversation with each of these topics. So when we talk about housing, behavioral health is definitely going to be a key component of that conversation. So I think instead of replicating a separate one just for behavioral health, we're looking for ways to include it throughout all of the conversations.
Thank you.
You mentioned stigma and its relationship with negative health outcomes. Did you source any data, or do you recall seeing any comments from survey participants about feeling like the healthcare system as it exists, particularly in a rural community like ours, doesn't provide enough time or access to primary care providers to be able to discuss in an appropriate level of detail things like substance use disorder that people are struggling with, and particularly with the folks that are on Medicaid that you mentioned?
Yeah, so I'm going to, in the chat, I'm going to put a link to the full presentation, and at the end of the presentation in a moment, Deborah's going to share some more resources as well, and they really go into the data for sure. One second, I'm trying to multitask. So that little URL that starts with the T, copy and paste that. That should take you to a full slide deck. We definitely did hear that, where there's just a nature of responding, and there's not really time built into the schedule or even the resources to build in time to really build connections with clients in a way that they can address those behavioral health needs, that's address the stigma or even combat the stigma. So we're definitely hearing from our partners and from the people who responded to our research methods, a need for supportive workforce, where I think some of those trainings that we mentioned, whether it's trauma-informed care or learning about bias and things like that, we're trying to come up with ways to make them more bite-sizable and doesn't necessarily require a week-long training or something like that, because we know there's a huge shortage in time and resources when it comes to the healthcare industry and our partners working on the front lines. So for example, one of the things OCH is working on is a mini video series of 6 different health topics, and one of them, if not more, will be devoted to stigma. And those videos will be 15 minutes or less, really boiling it down to what are some ways that we, with community members and health leaders in the Olympic region, can address these topics. So yeah, we're definitely hearing that there is a shortage of time and resources, and we're trying to come up with creative ways to address that. And I realize we're at 4 o'clock just about now. So if you scroll through that final presentation that I just put in there, at the bottom, there's a link to a bunch more resources. And I really encourage you to explore them with curiosity and also think creatively. Sorry, Lori, I know that was crammed.
You did incredibly well. Thank you, everybody, for floating with what has just been a really odd afternoon. There was so much in that presentation that was useful and worth looking at more closely. I want to thank you guys for the incredible job you did in pulling together just an overview of our whole region and of gathering our insight at this table. I think at the next meeting, what I'd like to do when we have the whole consortium here is to look at what can we do at this table that is in line with and weaves with what OCH is doing. You may remember a part of our grant was specifically to address stigma in Jefferson County. So I think we've got all the data now. Now we need to come up with some real actionable things that we can do in the last 2 years of this. And you guys, the foundation that you gave us to do this is incredible, and we could never have done it on our own. So thank you to OCH and Amy and Debra for presenting all of this information to us so clearly.
Well, thank you for your participation in the past focus group. We couldn't have pulled this together without your insights. So thank you so much for your time and perspective.
As I'm closing out this meeting, which I recognize everybody has to leave, and we've lost a lot of people already, I wanted to, before the end of the year, have a vote on our proposal from the Pfeiffer House. And so what I think I'm going to do is send out an email and get the votes that way. And and then I will announce what the outcome is at the January meeting. So please, if you see that email come, please give me your responses quickly so that we can turn around and put together a budget amendment for the grant to use those funds that we did not use in the first year, get them back out into the community to Kelli Parcher's project, if you believe that's a good use of the funds. So I think that's all I've got. I appreciate you guys hanging with us. Any last comments before we go? All right, go forth, have a great